Welcome back. Let us look at our third installment of this session of water-soluble vitamins. In this session, we are going to look at vitamin C, folic acid, and cobalamin. So what do we know about vitamin C? Vitamin C is also known as ascorbic acid, and interestingly, it has a structure that resembles that of a carbohydrate. It is heat sensitive, and we know cooking destroys the vitamin. And so if we are expecting to get the vitamin from cooked food, as much as 70% of it will be lost. Again, of interest is that vitamin C does not have an active coenzyme form. Okay, it acts as a strong reducing agent. So here is a structure of vitamin C. It resembles a six carbon hexose. Okay, it looks like almost like glucose, and it can exist in two forms. There's reduced form, where we can have the two hydrogen groups on carbon number 2 and 3, or they can lose the two hydrogen groups, okay, and it becomes in the oxidized form, which we refer to as the dihydroascorbic acid. And remember, we mentioned earlier that every time hydrogen moves, it moves with electrons. So this acidic property is because of the hydroxyl groups, which we have seen they can donate or accept hydrogen ions and electrons. And so that's why it acts as a strong reducing agent. And as we said, it can move through oxidation and reduced form. So both forms are biologically active. Both the ascorbic acid and the dihydroascorbic acid are biologically active. So what are the biochemical functions of vitamin C? So vitamin C has several biochemical functions. One function is that vitamin C is very important in collagen formation. So we know collagen is a protein, is a fibrous protein, and it is made up of sheets of collagen that are held together. And these sheets are held together by hydrogen bonding. So where does this hydrogen bonding comes about from? We have these amino acids, proline and lysine, that are hydroxylated. We have OH groups added to them, and then now these OH groups can serve as a point for creating hydrogen bonding between one collagen chain and another one. And this is what we refer to as collagen cross-linking. So now where does vitamin C come in? Vitamin C comes in the addition of the hydroxyl groups to proline and lysine to form hydroxyproline and hydroxylysine. Here's an example. You can see here is our proline. It is hydroxylated with ascorbic acid as a cofactor, and we can see we add a hydroxyl group here that was not present previously. Okay, it was CH2, but now we have CH and an OH attached to this carbon. So these OH groups can now participate in cross-linking through hydrogen bonding between different sheets or different chains of collagen. Okay, so this is collagen cross-linking is responsible for the strength of collagen. So we can see vitamin C, to summarize, is very important in creating hydroxylating proline and lysine, which plays an important role in collagen cross-linking. Another role of vitamin C is that it is important in absorption of iron. So iron can be absorbed in the iron 2 form. Iron 2, we are going to talk about this when we talk about minerals, but iron 2 is the form that is absorbed. This form is common in animal products, like if we eat meat or liver, they are rich sources of iron 2. However, plant sources are also good sources of iron, but their iron is in the form of iron 3. The iron 3 cannot be easily absorbed. So vitamin C allows conversion of the iron 3 to iron 2. And we can see when you see the 3 pluses, it means the iron is lacking 3 electrons. So vitamin C can donate electrons to iron 3 to make it iron 2. Okay? And so when it becomes iron 2, this is the form that can be easily absorbed. So deficiency of vitamin C can result to anemia, especially if the dietary sources of iron are plant sources. Another role of vitamin C is antioxidant. I think this is the one we know about it. It has an antioxidant role. We have seen the OH groups can donate hydrogen, and this hydrogen or electrons can be used to neutralize any free radicals that can come either from or that can originate from oxidative damage. So this antioxidant property is what allows us to fight infection and also to reduce the risk of cancer and coronary artery disease. I can give you one application, clinical application. We know when we have coughs and flus or viral infections, we recommend people to consume vitamin C. Why? Because vitamin C is antioxidant property. We know our immune system will fight infections by production of free radicals. The process of fighting the infection causes production of free radicals. And so these free radicals, they cause the general malaise people feel when they have an infection. And consumption of vitamin C helps to neutralize these free radicals and provides relief, although we know vitamin C is not a treatment. So another role of vitamin C is that it is important. It enhances the synthesis of immunoglobulins. Okay, it enhances synthesis of immunoglobulins, which are also known as antibodies, and also it increases the rate of phagocytic functions of leukocytes, and these are very key roles in the immune system. Antibodies and phagocytosis are very key functions of the immune system that helps the body to fight infection. Vitamin C also is very important in the synthesis of corticosteroid hormones, and these corticosteroid hormones are very important in the regulation of blood sugar, cortisol. We are going to learn about this. So they are important in the hydroxylation reactions in the synthesis of corticosteroid hormones. Remember, corticosteroid is a steroid-based hormone. Vitamin C is also important in bone formation and also in the creation of the ground substance that we find in the capillary wall. So it is important to maintain the integrity of both bone and the capillary wall. So when are we likely to have deficiencies of vitamin C? One, of course, poor diet. Poor diet, like we know, like if vitamin C is a water-soluble vitamin. And we have seen with water-soluble vitamins, if you don't consume this vitamin, we can likely have deficiencies within a matter of weeks or days. So a poor diet that is low in foods that are rich in vitamin C is likely to cause deficiencies. I think the story of the pirates, and we see many of them without teeth, and we know scurvy was discovered when the people were taking long trips in the oceans in the past. And so the crew in these ships were having features of deficiencies of vitamin C because they never carried citrus fruits. And so this is when we have the stories of the pirates with missing teeth and things like that, and bleeding gums because of poor diet. Another cause is because of severe stress and trauma. So severe stress, one of the body responses is production of cortisol, and you've seen cortisol requires vitamin C for its synthesis. So there's increased utilization of vitamin C. So here there's increased demand. Smoking is a very interesting cause because you see smoking causes lower serum levels of vitamin C, and the RDA of vitamin C increases to as high as 110 to 125 milligrams for smokers. So there are so many hypotheses that are trying to explain this, but maybe we could think about the free radicals that could be produced by the body in an effort to combat the products of smoking of nicotine. Interestingly, oral contraceptives and corticosteroids also cause deficiency. We've seen corticosteroids because of high demand, but also oral contraceptives. When people on this, they need to increase their RDA or their consumptions of vitamin C. So because of the different features we have learned about vitamin C, the different functions, so it will also have diverse manifestations. But generally, these manifestations are known as the disease called scurvy. One of the features is hypochromic microcytic anemia. This is iron deficiency anemia, and we can see because will not be able to form iron 2, which can be absorbed. We have seen vitamin C is important for maintaining bone and capillary. And so what we're going to see in deficiency, there'll be hemorrhages under the skin because the capillary walls are not strong, bone fragility, and joint pain because also bone is not strong. Another thing will be poor wound healing and frequent infections. This is because of its role with collagen. If the collagen cannot form the hydroxyl groups in proline and lysine to cross-linking, there'll be poor wound healing and also frequent infections because of the poor functions of the immune systems. We had seen vitamin C is important for phagocytosis and also antibody production. Again, related to collagen, there'll be spongy and bleeding gums and loosened teeth. And this is what I was telling you, the loosened teeth that can easily come out, which we've seen when you think about the pirates, when you see them in the movies, you see most of them have a missing tooth or two. This is because of scurvy, because of the loose gums and the loosened teeth, of the bleeding gums and loosened teeth. So that's what we have about vitamin C. Let's look at folic acid. Folic acid is one of the B vitamins, and why I put folic acid and cobalamin separately from the other B vitamins is because the other B vitamins we have seen, they are very important for production of energy. However, these two, folic acid and cobalamin, they play important roles in hematopoiesis. So if we start looking at the structure of folic acid, it's pretty complex. It has as part of it to refer to as the pteridine ring, which is made up of two rings. Then next to it, we have the molecule of PABA or para-aminobenzoic acid. Okay, and the two of them form what we refer to as the pteroic acid. Then we have glutamic acid added to the pteroic acid, and that's what we refer to as the pteroyl glutamic acid or folic acid. Okay, so it has three constituents, as we have said, the pteridine, the PABA, and the glutamic acid. Okay, so of interest in our body, clearly we cannot make this ring. Okay, we cannot make this ring, and so we have to obtain it from diet, but some bacteria can make it. So once we get folic acid from diet, we are able to create it to the active form by a very important enzyme referred to as dihydrofolate reductase. The hydrofolate reductase adds 4 hydrogen groups to the folic acid. You can see here 1, 2, 3, 4 to give us our 5, 6, 7, 8 tetrahydrofolic acid. So you can see we're moving from folic acid to tetrahydrofolic acid, which is the active coenzyme form. Here you can see who is the codonor of these hydrogen groups. You can see it's NADPH. We talked about it in the previous class. NADPH is the donor of hydrogens here and electrons clearly, and now they are added to folic acid to give us our active form, tetrahydrofolic acid. So as we mentioned, this is a NADPH dependent reaction. So what is the biochemical function of tetrahydrofolate, the active coenzyme form? So tetrahydrofolate is involved in one carbon metabolism. What I mean in one carbon metabolism, we could transfer one carbon group in different forms, either in biosynthetic or catabolic reaction. So tetrahydrofolate plays an important role in this one carbon reaction, metabolism. So it can act as an acceptor of the carbon group or a donor of one carbon group. So these are very important reactions in amino acid metabolism and nucleic acid or nucleotide metabolism. So here is a good example. We have our tetrahydrofolate can accept a one carbon group to form carbon tetrahydrofolate in different forms, and then it can donate this carbon group in different reaction. Okay, or it can donate it to amino acid to synthesize glycine or serine. It can donate it in the synthesis of purines. It can donate it in the synthesis of thymidylate and also in the synthesis of choline. So it can, as we said before, it can accept the one carbon group, and then in the form of carbon tetrahydrofolate, it can donate the hydrogen group in biosynthetic reactions. So the one carbon group can be accepted or can be carried in different forms. It can be carried in the form of a methyl carbon, we can see CH3. It can be form of a methylene group, okay, or CH2 or a formyl group. Here are all different examples. We can see here we talk about methyl tetrahydrofolate, and this methyl group is attached to N5, so we talk about as N5 methyl tetrahydrofolate. It can be in the form of methanol group, where the carbon group is attached to nitrogen 5 and nitrogen 10. So we say N5, N10, methanol tetrahydrofolate. Okay. It can be in the methylene form, where the carbon is now attached again to N5 and N10, but it's in the form of methylene. So we talk about N5, N10, methylene tetrahydrofolate. So you can see these are major points. The nitrogen 5 and the nitrogen 10 are major points of carrying the one carbon group. Okay. So where do we use this? Which are some of the reactions where we see the utilization of the tetrahydrofolate to donate the one carbon group? We can see it is used in the synthesis of purine. In fact, carbon number 2 and carbon number 8 of the purine ring is donated by by tetrahydrofolate. Tetrahydrofolate is important in the synthesis of glycine from serine, where it accepts one of the carboxyl groups, this one. Okay, it accepts this carbon groups, and it carries it in the form of N5N10 methylene tetrahydrofolate. It is also important in the synthesis of choline, and we know choline, we have seen it in phospholipids. We talked about phosphocholines and also in acetylcholine. We're going to see these reactions when we talk about the synthesis of these molecules. It is important in the synthesis of pyrimidine nucleotides, the thymidyllic acid. We're going to see how this is formed. And we know DTMP is only found in DNA. It is not present in RNA. Here we have a reaction of synthesis of methionine. We talked about synthesis of how homocysteine can be used to synthesize, homocysteine can be converted to methionine, and N5N methylene tetrahydrofolate can donate a methyl group to homocysteine, and we can make it to methionine. But this does not occur in the human body because methionine is an essential amino acid which must be obtained from diet. So when are we likely to get deficiency of folic acid? The first one is in pregnancy. Pregnancy, where there's increased requirement because of fast cell division. And this we've seen very clearly. Folic acid is important as a methyl donor in the synthesis of purines and pyrimidines, which are used to make DNA and RNA. And in cell division, we have increased production of DNA and RNA for the processes of mitosis, although the cell can divide. We have a lot of protein synthesis, so that we'll be having a lot of transcription and translation, as well as replication of DNA. So there'll be increased requirement of the nucleotides. And this continuous synthesis of nucleotides requires tetrahydrofolate. We have seen in pellagra that which is due to deficiency of niacin, okay, can lead to folic acid deficiency because niacin forms NADPH. And we see NADPH is the donor of the hydrogen groups in the dihydrofolate reductase reaction that activates folic acid. So if there is deficiency of niacin, there will be lack of NADPH, and so we'll be unable to activate folic acid. Of course, we have seen folic acid is predominantly from animal sources, so it's very low or absent in vegetables, and so a strictly vegetarian diet will have deficiency. And also vitamin B12 and B6 and B12 deficiency will also indirectly cause deficiency of the folic acid. And hemolytic anemia, where there's increased breakdown of red blood cells, that means we need to form more red blood cells. And again, the synthesis of more red blood cells is going to require folic acid for DNA synthesis. We have here a clinical correlation where we have some drugs like anti-cancer drug like methotrexate. This methotrexate drug specifically inhibits dihydrofolate reductase. Dihydrofolate reductase we have seen is the enzyme that is required to activate folate to the active coenzyme form tetrahydrofolate. folate. So the methotrexate will inhibit dihydrofolate reductase activity, and so we cannot form tetrahydrofolate. And so all the functions related with tetrahydrofolate, especially of nucleic acid synthesis, will not occur, and that's how we inhibit continuous growth of the cells, of the cancer cells. So one of the major manifestations of deficiency of folic acid will be in the peripheral blood, where we're going to see an anemia. However, the anemia will be different from what we've been talking about, the hypochromic microcytic. We'll be seeing macrocytic anemia, where we see large distorted red blood cells with a mature nucleus. So if we look at the bone marrow, here we have our normal marrow. We have a few megaloblasts, huge cells, which mature into mature red blood cells. But in megaloblastic marrow, we're going to see huge megaloblasts which have like stalled. They are unable to develop into mature red blood cells. So some of these large cells are passed into the blood. So this hematological picture will resemble that one of vitamin B12 deficiency, and we are going to see another major feature which I'm sure you know about, especially the midwives, is the neural tube defects. And this is the reason why we advise women to consume B12, to consume folic acid even before they think about getting pregnant. So folic acid deficiency, especially during early pregnancy, can result to spina bifida. And we know there are several levels of spina bifida, from failure of closure of the skin, to closure of the spinal cord, to hanging out of the spinal cord and the the meninges, all this. So we really want to prevent these neural tube defects, and so that's why we advise women to consume folic acid as early as at the beginning of when they're thinking about getting pregnancy. And we know folic acid deficiency is the most common vitamin deficiency. So finally, we can talk about vitamin B12. So vitamin B12 is quite a complex ring. The structure is quite complex. It contains what we refer to as a corrin ring. And this corrin ring is made up of 4 pyrrole rings. We can see the pyrrole. This is 1, 2, 3, 4, the 4 pyrrole rings. And at the center, we have cobalt. So we refer to this as cyanocobalamin. At times, this cobalt can be replaced with methyl. We call it methyl cobalamin. Or it can be replaced, we can have a deoxyadenosyl molecule attached to it, and we refer to it as 5-deoxyadenosyl cobalamin. So we see that this cobalt is held at the center of the corrin ring by 4 bonds with the nitrogen of the pyrrole ring. Okay, so the 6th bond is with a molecule of cyanide. So here we have our cobalt held by 4 nitrogen bonds to each of the 4 pyrrole rings. Okay, and one of the bonds is with a molecule of 5,6-dimethyl benzyimidazole to the cobalt ring, and the 6th bond cobalt is attached to cyanide, so giving this molecule the name cyanocobalamin. So vitamin B12 or cobalamin has 2 active coenzyme forms. We have the deoxyadenosyl cobalamin, where the cyanide is replaced by 5-deoxyadenosine. And then we have the methyl cobalamin, where the cyanide is replaced by a methyl group. So we have either methyl cobalamin or deoxyadenosyl cobalamin, which are the 2 active coenzyme forms. So of interest, vitamin C, we can say it's a big molecule, so absorption cannot be so very easy across the GIT. So first of interest is that vitamin C is actually absorbed in the stomach. Is absorbed in the small intestine. However, for it to be absorbed, it requires a protein referred to as the intrinsic factor. And this intrinsic factor is a glycoprotein that is produced by the stomach. Okay, so once vitamin B12 is consumed in the diet, in the stomach it binds to intrinsic factor, and the intrinsic factor is the one that facilitates its absorption in the ileum. Once it is absorbed, because of its large nature and complex, vitamin B12 is transported in blood in the form of hydroxycobalamin, which is bound to another protein referred to as transcobalamin, and that is transcobalamin 1 and 2. So transcobalamin protein is the one that transports cobalamin in the bloodstream and transports it to the liver. Now, at the earlier, we mentioned that cobalamin is the only vitamin, water-soluble vitamin that is stored, and is stored in the liver in the form of deoxyadenosyl cobalamin. So please remember this protein, the intrinsic factor, which is a glycoprotein, transcobalamin, which carries the cobalamin in the bloodstream, and the storage form of deoxyadenosyl cobalamin. What are the biochemical functions of the cobalamin? So one of the functions is the synthesis of methionine from homocysteine. So we have the enzyme methionine synthase. And homocysteine methionine synthase can get a methyl group from N5-methyl tetrahydrofolate to give to homocysteine and to make it methionine. So in vitamin B12 deficiency, there's increase in N5-methyl tetrahydrofolate because the N5-methyl tetrahydrofolate conversion to tetrahydrofolate is blocked. Okay. So with this reaction of the synthesis of methionine is not working because cobalamin is deficient. So the folate becomes trapped in the form of N5-methyl tetrahydrofolate, and this is known as the folate trap. So we are saying that B12 deficiency will result in decreased folate coenzymes, tetrahydrofolate, that leads to reduced nucleotide and DNA synthesis. And that's why we could see if we have reduced DNA and nucleic acid synthesis, that's why we could see similarities in the megaloblastic anemia between folate deficiency and cobalamin deficiency. Cobalamin is also very important in isomerization of methylmalonyl-CoA. So this is an important reaction in the degradation of fatty acid with odd number carbon atoms, and also in the degradation of branched chain amino acids. So when the fatty acids are broken down with odd number through beta oxidation, they end up with a propionyl-CoA, which several steps results to methylmalonyl-CoA, which has to be converted to 6-alkyl-CoA, which is an intermediate of the TCA cycle. This particular reaction, conversion of methylmalonyl-CoA to 6-alkyl-CoA, requires an enzyme methylmalonyl-CoA, which requires vitamin B12 as a coenzyme. Okay, so if vitamin B12 is deficient, you're unable to form 6-alkyl-CoA, and you are likely to have accumulation of methylmalonyl-CoA. And this methylmalonyl-CoA is passed out in urine, and it is called methylmalonic aciduria. So if vitamin B12 is deficient, we'll have accumulation of the abnormal fatty acids with these ones with odd number, which are incorporated in the cell membrane of the nerves, and this will result to neurologic manifestations. So how can we get deficiencies of vitamin B12? First, vegetarians, we've seen B12 is also very common in animal diet. So strict vegetarians are likely to be deficient in vitamin B12. We can have decreased absorption because we have gastrectomy. So we have seen intrinsic factor is produced in the stomach. If it is deficient, if the stomach is cut off, we'll have it reduced production of intrinsic factor. And in malabsorption, where we have problems with absorption, it can interfere with the absorption of B12. In pernicious anemia, we have antibodies that are formed against the intrinsic factors. So this is an autoimmune disease. So antibodies destroy any intrinsic factor that is produced, and so because they are destroyed, they cannot bind vitamin B12 and facilitate its absorption. So this is what we call pernicious anemia. Again, in pregnancy and lactation, there's increased demand, and also in alcoholics, the liver is not able to store some B12. So similarly to folic acid, deficiency of B12 will present with megaloblastic anemia. We're going to see large immature red blood cells. In addition to this, B12 deficiency will present with nervous system manifestation, where there's degeneration of the nervous system due to demyelination, as we have seen, because of accumulation of the abnormal fats. So we are saying that the hematological picture of B12 deficiency is similar to folic acid deficiency. Now, folic acid can partially reverse the hematologic abnormalities of B12 deficiency, but it cannot correct the nervous manifestation. So this is one of the ways you can know a difference between B12 and folic acid deficiency. B12 will have a nervous manifestations, we have seen, because of the degeneration of the nervous system. So when we see megaloblastic anemia, it's usually wise to start treatment with both folic acid and B12. Unless it is pernicious anemia, then we have specific mechanism of that. So we have come to our long session, the end of this long session of water-soluble vitamins. We have looked at all these vitamins. We've looked at their functions and their presentations. Thank you so much for your time. Nice time. Meet you next time.